system and some of the concerns that you're raising. We have an audience here in the hotel that we're in, and we're also getting your tweets. And just before the break, we started talking about HIV, and one person here, Mashumane, says, young men out there believe that all they need to do now is be circumcised and they won't get HIV. Are we being careful with the way that we're sending this message out about the relationship between catching HIV and circumcision so that these young people don't think that all they need to do is get circumcised and they're immune?
I don't know which young people are thinking like that. I don't know. Because that issue has been discussed long ago. It's no longer a debate. It's known around the whole world now that when you circumcise people, they decrease the chance of getting HIV by between 50 and 60%. That's enough. That's why we're going to circumcise 4 million men in South Africa. We have just done 1 million. There was this argument that they will think that circumcision is like a condom. It's not. And during the circumcision, they go through that counseling. There was a research that was done and found that 80% of the people who are circumcised still understand that they still have to use condoms. Because we don't do this circumcision as mechanical. They must go through counseling and they must be taught what this is all about. If you look at KZN, that's where it's working excellent because it was instituted by the king himself. Remember the Zulu nation, King Shaka stopped circumcision 200 years ago. And King Zwelithini brought it back, whereby it's been done both traditional in terms of the traditional laws. They send old men there to teach to these young men. We send our counselors to talk to them. So they go through 2 steps. Old men talking to them about their culture, counselors talking to them. It's then that you send doctors. You don't just send doctors and start dipping for skins.
To be clear, and I just want you to say that to this
they
camera
have to
there.
Use condoms.
Please
also.
tell the young people very clearly.
They must circumcise and use condoms.
Okay.
They have to. There's no escape from that.
Okay, so it's just another level of security, but you must still use
double
condoms.
Protection.
Okay.
Double protection.
All right.
You must double protect yourself double because it's a problem. You know.
All right.
Yes.
Table 19. Lynette to Blanche. This is a question that's come through Twitter as well. Lynette, table 19.
And good morning, Minister. Medicine supply remains a challenge in South Africa for a number of reasons.
The what?
Medicine
supply.
Yes.
However, we know that one of the reasons is as a result of necessary variations taking a very long time to be approved by the regulator. Is there anything that is going to be done in the short term to address this issue?
Yes, absolutely.
Okay.
Absolutely. This has been a thorn in the flesh for a long time. Our regulator, the MCC, where pharmaceutical companies apply for registration, not a patent, registration. And they've got to wait for many years because MCC doesn't have capacity. This is what we are doing. There is already a law in Parliament. Unfortunately, it can't go on during this session. It's too late. But it will start immediately in the new session to establish what is called SAPRA, South African Health Products Regulatory Authority. It's an authority that is going to be having more capacity, bigger, regulate not only medicines, but even devices, because they are not doing that now. But you need human beings to do that. In April, next month, we've been working with FDA, Federal Drug Administration in America, and regulatory authorities in Europe. In April, we are opening an institute. It's a virtual institute. It's not going to be buildings as such, but it's going to be an institute that trains people in regulatory medicine, because one of the weaknesses which makes MCC weak, Peter, is that there is no single university in the whole South Africa. Of all the 23 universities and universities of technology, there is none that trains anybody on regulatory medicine. We've already identified students, people who have got a master's degree in science, MSc. They are going to be the first students in this institute. We are going to bring people from Europe and America to train them in this issue of regulatory authority. The third thing that we are doing in the short term, we are trying to find relationship between us and the other regulatory authorities. If they've already gone through a particular medicine and they've registered it. Should we still repeat the process here, or we just take from them and include it? So that one is about to happen also. So we are doing quite a number of things to improve this.
Okay, so that's one aspect of it. The other is I'm getting a message that community clinics, people are being turned away because they don't have HIV drugs available. What are we doing about shortages?
Well, Peter, there are two things here that are related. One you asked long ago, and I didn't. You asked earlier on, and I did. Yes, the issue of queues. I want South Africans to understand the trouble the country is facing. In 2004, we had 400,000 people on ARVs. In 2009, there were 923,000 people on ARVs. Today, there are 2.4 million.
Wow.
The number of nurses and the number of clinics are not increasing at that rate. We are a society that is bedeviled by the burden of this disease. 2.4 million people going to clinics and hospitals every day, collecting medicines. Just go here, next door to Helen Joseph. The biggest ARV clinic is there. You'll find that they can get up to 800 people coming in one day to cure for these medicines. So it is a problem of access has been open. And remember, in the next 24 months, that figure must grow to 4.6 million. If you calculate it, the number of people who receive ARVs in South Africa is 30% of the total number of people in the whole world. So what are we doing about it? In April, again, we've been trying to study these things. We are launching a project called Chronic Medication. It will work like this. And we are going to start in the 11 pilot projects. We are already about to launch. All the patients who are stable, that means who just goes to the clinic to collect their medicines, they are stable, they don't have to be seen by any doctor or any nurse. They are no longer going to have to go and queue at the clinics. They will choose, and we have already asked them, they are busy choosing those patients who have been identified. They will choose a facility next to where they stay, not a government facility. Either a private doctor or a private pharmacy or a community pharmacy or any institution of public interest, and say, go and deliver my medicine there. We will go and deliver these medicines in their names, and they'll go there and collect it. It will also help us to see who doesn't have any medication, because this shortage of drugs in the country, in the clinics, it's not a shortage of drugs in the country. It's a problem of logistics. That is why I rejected late last year when they were saying this is a national crisis. It's not, and I'll tell you why, Peter. Especially for HIV, AIDS, and TB. At any one time, we keep 10% of stocks, which we call a buffer stock. That means we make sure that 10% of all the drugs are kept by a company at any one time. If there's a crisis of manufacturing, there will only be a crisis if that buffer stock disappears and it's no more. Then we'll say there's a crisis because there's nothing. So at the moment, what people must do, we are giving them a number. Unfortunately, I don't have it. Yeah. I didn't know that this was going to come. To tell us if they experience a shortage in one clinic, because it just means the shortage is in that clinic, we can run somewhere and get these drugs. Okay. But we believe this chronic medication will help us also solve that problem, but also solve the problem of the long queue so that you don't have so many people going to collect the drugs.
I keep asking you this question over and over again, because it sounds at a national level, you've got great ideas, you've got great plans, but you lose control a little bit at a provincial level because now another layer of government takes over. Is that problem going to go away? Because Tembiso is saying that TB management in Mpumalanga is poor, our community is in danger. Please intervene, Minister.
Well, I'm not sure what you mean because it's not specific. We do intervene all the time because at the national level, Bita, is true. You set norms and standards and policies. The implementation is happening at that level. But because of this weakness and uneven implementation, we're trying to make some of the things at national level. Like, for instance, in the pilot districts, this improvement of facilities, building new facilities, renovating equipment in all the 11 pilot districts of NHI, we are doing that project at the national level to make sure that it's even. and not unequal, as the person is saying. But in terms of policies and norms and standards, we're trying to do them at that national level. Even with the ordering of, the procurement of drugs, ARVs, it's not done in the province. We procure at the national level, sitting with them.
Okay.
All they have to do is to order. And that's where the problems comes in, because if they don't order on time or distribute on time, then you'll have that clinic having no drugs.
Okay.
When we know that we have got lots of drugs, including the 10% buffer stock that is still there.
Logistics is the big issue then. Table 20, Marange. Marange, table 20.
Oh, thank you very much. Good morning, Minister, and good morning, Peter. My question would be, Minister, what are you doing about traditional medicines? I grew up getting a lot of traditional medicines, and we find that a lot of old people today, they still have those concoctions which actually help, maybe also complement the pharmaceuticals. Thank you. And the demand for them worldwide is growing. Why should Africa not start now to develop also our small medicines and complement the pharmaceuticals, and also have our patents to that effect?
Okay, traditional medicines?
I don't know why you're saying why should Africa not start now. Africa declared the past decade a decade of traditional medicine. The past decade, not the present decade. They declared it a decade of traditional medicine. Unfortunately, very unfortunately, few African countries, not only South Africa, has got anything to show about it. Why, during that decade of traditional medicine, what actually happened? So this decade was declared again, another decade of traditional medicine. The World Health Organization got worried about this. When the Africa region of the World Health Organization in 2012 met in Cote d'Ivoire, there's a professor, she's from Tanzania, I think yes, Professor Osi Casilo, she's a professor of pharmacology. She seems to be the only expert who understands how this thing should be done. That's the weakness of Africa. Most of the people I've met, they actually don't know what we mean when we say this is a decade of traditional medicine in terms of implementing, in terms of doing. Now the professor said the problems are three. Why Africa is lost in this whole issue. Declare the decade and do nothing. She said the problems are three. The first one is the product. What product do you call traditional product? If you meet a root of a tree, and say it can treat HIV and AIDS, what proof do we have? And she said that's not a big problem, because many universities around Africa, including South Africa, are already doing research about that, about natural roots and herbs, which are gathered traditionally, and they can subject them to science, She says the problem starts when you come with number 2 and number 3. Number 2 being, who is the practitioner? Who is practicing this? How do you define this person and say this one is practicing traditional medicine? That's why we establish a special committee to deal with that. The last problem, the professor said, is the practice. What is this practice that you call traditional medicine? I think the World Health Organization made it worse by their definition. Their definition of traditional medicine says any practice that is believed by people in that area. It doesn't have to be scientific. It doesn't have to be proven, as long as people believe it in that area. I found that definition very problematic. And when you go to apply it on the ground, where do we start? But coming to South Africa, we have got a committee of traditional leaders within the Department of Health. There's a special commission which is paid for by the department, which must help solve some of this problem. My experience is that they push them back to government, For instance, when I ask them, who is the practitioner? There are times when they say, no, it's the minister who must choose. Now, I've got no skills in that to choose who is practicing what. So it's clear that it's an area in South Africa
Let me ask
that
you
we
this
need
then.
to solve. The Medical Research Council has got a unit, inside it, which must also do research about this issue of traditional medicine.
Let me ask you this. Will I be able to use the NHI to see a Sangoma?
You see, those are the problems that we have not yet determined.
Okay.
Because once we say yes, who will come? There was a debate in South Africa whether you can use your medical aid on traditional medicine. But if you can't answer these 3 questions,
Then it becomes
where are you going to start?
Okay.
If somebody can give me an answer, clear answers to these 3 questions, not ambiguous, and so we actually are able to set them. But as far as I've attended meetings, I remember, Peter, they said Ghana is the one country that is very highly advanced in this field. When the World Health Organization met, we asked the Minister of Health in Ghana to brief us. Why do they say they are advanced in this area? When he explained, we found that no, it's not talking about traditional medicine as is explained. It's talking about herbal medicine.
Okay.
Where in Ghana they take people traditionally from rural areas, take them through institutions, academic institutions, and train them in the use of herbal remedies and all that. And now that it doesn't, it solves the problem of product. It doesn't solve these 2 problems.
Okay.
You are aware that Zimbabwe was the first country after President Mugabe took over, which was integrating this present healthcare system with traditional medicine. When the ANC was still in exile, I'm one of the people who went there. We're meeting ANC through NAMDA. And we called the director of health to explain to us how this thing works, because we thought after liberation we must do it immediately. That system has collapsed in Zimbabwe. I met their Minister of Health and asked him, how have you done it? He said, no, it has collapsed because we also did not understand it very well. It's no longer there.
All right. Just before we go for a quick ad break, talking about traditional medicines, medicinal marijuana. What are your views on this? Lesia Mudibedi would like to know.
Peter, let me explain this to the public, and I want them to understand. There is nothing new in here.
Yeah.
What is new which caught your attention and excitement is that the call was made in the most powerful place in this country, in Parliament, by one of the most powerful people who have been given power by virtue of a vote. That is what is new. If you look at the Medicines and Related Substances Amendment Act, you will find that it defines this issue. Section 21 of that act. If you want to use a banned substance to treat yourself of a disease that for which there is no other cure known, and the substance you want to use is banned, and we are dead sure in healthcare we don't have any substance, you can apply to the Director General of Health. They can allow that. They can give you a permit. The problem is that people want a permit for everybody, even for those who are not sick. That permit that is given by that act is yours and is given on compassionate ground. Section 22.
But where do you take this permit? Do you go
to
a dealer
MCC.
on the side of the road?
Sorry?
But if I want to buy marijuana,
Sorry?
If I want to buy marijuana, who do I take this permit
No.
to?
I'm telling you in terms of that law.
Yeah.
You take that must be done by the MCC,
Okay.
the Medicine Regulatory Authority, and the DG of Health will approve it in terms of the act. The problem that South Africans are looking for, you want to use the misfortune of one person, all of you. Yes, because if we give that permit to that one person, the permit belongs to that person, not to you, Peter, because you are not suffering from a disease that needs that. But the second thing, Peter, I've got the Cancer Advisory Committee that sat and look at these issues. Does marijuana treat cancer? Does it do that? I've got the Cancer Advisory Committee that consists of professors, cancer activists, and even survivors, people who suffered cancer themselves, who are advising me about this. At the moment, what is emerging is that, yes, pain, in terms of pain, vomiting, and all that. But in terms of treatment, it still needs research. There are professors at University of Cape Town and Medical Research Council who are writing an article about this, having checked literature all about the world. Finally, Peter, if people want to use marijuana unbanned and they want to use it recreationally, like they do in Colorado, they must not come to the Minister of Health. Yes.
Okay.
As a Minister of Health for treatment, we will give you a permit for your specific treatment. And by the way, 2 years ago, a permit was given for somebody here in this country to use marijuana for glaucoma. So I'm not talking about something
Okay.
that's new. What is new is that you are making a call for everybody to use. That is not going to be answered by the Minister of Health. It
Okay.
must go somewhere else.
Police.
Yes, not to me.
All right, we're going to take a quick break, and when we come back, we're going to get into the last 15 minutes of this conversation, so stay with us for that.